topic we have chosen to present is postpartum hemorrhage. I'm Casey, this is Cassie, and this is Brittany. Firstly, I'll give a brief overview of what postpartum hemorrhage is and the epidemiology of the condition. Secondly, Cassie will speak about the pathophysiology of the condition. And thirdly, Britt will use a simulated scenario to demonstrate how we as paramedics would manage this condition in the pre-hospital setting.
Postpartum hemorrhage is a condition in which blood loss occurs after birth. The hemorrhage is considered a postpartum hemorrhage when the estimated blood loss is in excess of 500 ml for a vaginal birth and 1000 ml for a caesarean birth. Due to the blood volumes of various different patients, the blood loss can be defined as any blood loss that causes major physiological change. Postpartum hemorrhage can be classed as primary or secondary. Primary refers to the hemorrhage occurring within 24 hours of delivery. Secondary refers to the hemorrhage occurring 24 hours after the delivery. Data of postpartum hemorrhages is variable due to the inconsistency in definitions of estimated blood loss, although the incidence of postpartum hemorrhage has increased significantly in Australia over the last 15 to 20 years. Currently, there is a lack of statistical data for PPH in the pre-hospital setting. Due to this, the data I have provided is from various hospital settings around Australia. The estimated Australian population incidence for any postpartum hemorrhage was 7.2 per 100 women who gave birth. In South Australia, during 2010, PPH occurred in 10.4% of births. In Queensland, PPH occurred in 5.9% of births. During a population-based study in Australia, it was found that the risk of PPH in any first pregnancy was 1 in 20 women, although the risk of recurrent PPH increases to 1 in 7 women for a second pregnancy and 1 in 5 women for a third pregnancy. Individuals and groups that are at higher risk of PPH. These groups include increased maternal age, more than 35 years, age and ethnicity, obese, those with a BMI over 35, women with pre-existing uterine abnormalities. Individual risk factors may include history of a previous PPH, prolonged labour, trauma, multiple pregnancies, placental abruption, uterine inversion. Research has shown that the incidence and prevalence of PPH is higher in developing countries than developed countries. This could be due to poor pregnancy management and lack of resources, reduced experience of health professionals, education, medications, and poor facilities.
The female reproductive system is responsible for the proliferation of the human species. It's made up of several major organs, as shown on the image here, which include the ovaries, uterine tubes, uterus, vagina, labia, clitoris, and mammary glands. As a collective, the system has 4 main functions, which are to produce female sex cells and hormones such as oocytes, estrogen, and progesterone, to provide support, protection, nutritional care, and waste removal for a developing embryo from conception to delivery, to provide milk to nourish a newborn infant, and to allow for sexual intercourse. The uterus is a hollow, pear-shaped internal organ that's situated in the pelvic cavity, superior and posterior to the bladder. In 80% of women, the uterus will bend anteriorly near its base, known as anteflexion. In 20% of women, the uterus will bend backwards towards the sacrum, known as retroflexion. Despite this being an anatomical variance, it has no clinical significance. The internal anatomy of the uterus at term is divided into 2 sections: the upper uterine segment, involving the body of the uterus and the fundus, and the lower uterine segment, involving the isthmus and cervix. As shown in the diagram, there are 3 levels of the uterine wall. Firstly, the perimetrium. Secondly, the myometrium, which is the muscular layer related to postpartum hemorrhage. In itself, it has 3 layers that all play a critical role in uterine contents evacuation that I'll expand on more shortly. And thirdly, the endometrium. The uterus is supported by the pelvic floor muscles, which are maintained in position by various ligaments. The most important in this setting are the cervix ligaments, including the pubocervical ligaments, which pass forward from the cervix under the bladder and to the pubic bones, transverse cervical ligaments, which fan out from the sides of the cervix to the pelvic walls, and the uterosacral ligaments, which pass backwards from the cervix to the sacrum. Throughout the mother's pregnancy, her uterus undergoes significant changes in preparation for birth. It will increase in weight from 70 grams to 1,000 grams by term, as well as size, so much so that it will have risen out of the pelvic cavity into the abdominal cavity by 12 weeks. Here it is no longer anti-flexed as it progresses to a position of right obliquity, meaning that it's vertical and rotated slightly right as the colon occupies the left side of the cavity. Here the fundus can be palpated just above the symphysis pubis. Blood flow to the uterus also increases from 60 mL per minute to 600 mL per minute by term. Postpartum hemorrhage, or PPH, is defined as excessive bleeding from the genital tract following the birth of the child. This is characterized by three main factors, including the time frame, estimated blood loss, and/or hemodynamic compromise. Time frame. So it's considered primary PPH if it occurs within the first 24 hours, and secondary if it occurs after 24 hours, but before the end of the puerperian period, or around the 6th week. For our patient today who's just given birth, she falls into the primary PPH category. Estimated blood loss. So this objective information relies on the paramedic's ability to estimate the amount of blood loss. For this to be considered significant, the bleeding must be greater than 500 mL for a vaginal birth, as stated by Ambulance Victoria. It's considered severe if estimated equal to or greater than 1,000 mL. Hemodynamic compromise. This includes a range of signs and symptoms such as the ones listed here. It can also include further complications such as hypovolemia, where the mother will present as hypertensive as vasoconstriction becomes more difficult, tachycardic due to the body raising the systemic vascular resistance in an attempt to maintain perfusion, low oxygen saturations due to decreased perfusion to peripheries in particular, and oliguria. This is a life-threatening condition for the mother because the reduced circulatory volume can lead to inadequate tissue perfusion. The clinical signs also often delay in newly parturient women due to the increased blood volume of pregnancy, so by the time symptoms present, she will have lost 1,500 ml or more. The Royal Women's Hospital described the causes of postpartum hemorrhage with the mnemonic of the 4 T's: tone, tissue, trauma, and thrombin. As mentioned previously, the first T, uterine atony, is the most common cause, so this is the type we're going to focus on today. Uterine atony is the failure of the myometrium fibers in the uterine wall at the placental site to contract and retract. When contracting effectively, this movement allows for placental separation and compresses any torn blood vessels, which helps to control blood loss as a living ligature mechanism. When this is unsuccessful, there is nothing stopping the bleeding, allowing the hemorrhage to ensue with often great speed. Causes of an atonic uterus include prolonged labour, where uterine inertia may result from muscle exhaustion, a full bladder because of its close proximity to the uterus, medications or drugs such as general anaesthetics that can cause the uterus to relax, placenta previa, and placental abruption. Timely recognition and treatment to cease the bleeding is therefore imperative in this life-threatening emergency.
Victorian, Queensland and New South Wales ambulance guidelines outline that the blood loss should equate to 500 mL or more to be classed as a postpartum hemorrhage. Guidelines from the Paediatric Infant Perinatal Emergency Retrieval Service provided by the Royal Children's Hospital outline that clinical estimated blood loss often falls below the actual amount due to the observations being subjective, resulting in postpartum hemorrhage being underreported in 30 to 50% of cases. Musa, Blum, Abuel, Sunun, Shakur and Alfeveric agree with this, further adding that blood loss is commonly underestimated by between 100 and 150 mL. You have been called to the home of a 27-year-old female who is experiencing bleeding after an unplanned home birth at 39 weeks gestation. Upon arrival to the scene, you notice a moderate amount of blood surrounding the patient, although at present she appears to be hemodynamically stable. You also note that the placenta has been birthed and is still attached to the baby, who is seen to be healthy and is being attended to by the patient's sister. As per the Ambulance Victoria CPG, standard procedure upon arrival to any scene first involves the application of personal protective equipment and the identification of any dangers. Following this, we will assess for a response in airway and breathing, all of which can be done upon initial contact with the patient. In this case, all three are present as she is communicating with us.
Ouch! Help me, I am bleeding.
Next, we will assess for circulation and assess the progression of the hemorrhage. Finally, we will assess for disability and exposure. To rapidly assess for disability, we can use the AVPU scale, or, for a more in-depth assessment, we can obtain a GCS score. As for exposure, the patient states she has not been exposed to any forms of trauma. Patient positioning is also extremely important in this case. Queensland maternity and neonatal clinical guidelines suggest a flat positioning when blood loss is less than 500 mL or if the patient is hemodynamically compromised. The Royal Women's Hospital go on to explain that when blood loss reaches greater than 1,500 mils, the upper third of the woman's body should be lowered with the rest of the body flat. Following the completion of the primary survey, we will begin to apply assessment tools, including the vital signs survey and the perfusion status assessment, obtaining the following information as outlined in the Ambulance Victoria CPG. This will enable us to prioritise our care, arrange for MICA, and to assess whether or not the patient meets the time-critical guidelines. We will also need to obtain a history from our patient, which can be done through asking simple questions. Relevant questions include: were you expecting any complications with this birth? How many pregnancies have you had? Have you had a postpartum hemorrhage in previous pregnancies? Have you ever had an antepartum hemorrhage? Have you experienced any recent trauma? Do you have any blood conditions? As discussed earlier, all of these questions are key in identifying patients who may be at a higher risk for a postpartum hemorrhage. Victorian, Queensland and New South Wales ambulance guidelines are all quite similar in the ways that they outline the treatment of a postpartum hemorrhage. High flow oxygen therapy, analgesia, management of hypovolemia, management of visible lacerations, and fundal massage are all outlined as initial treatment options. Following the New South Wales guidelines, they suggest that we first eliminate each cause of a postpartum hemorrhage and then treat accordingly. An atonic uterus is treated with a fundal massage. For trauma, we apply direct pressure to any visible lacerations, which will aid in hemorrhage control, and for retained products, we apply a pad and monitor blood loss. Following the Victorian guidelines, the first step of management involves assessing for fundus tone, visible blood loss and lacerations. All are managed as per the New South Wales guidelines mentioned previously. A firm fundus will be easy to palpate and should be central and compacted. If the fundus is firm, we will apply high-flow oxygen between 10 and 15 litres through a non-rebreather mask. The Royal Australian and New Zealand College of Obstetricians and Gynecologists outlines in their postpartum hemorrhage management guidelines that high-flow oxygen is recommended under resuscitation, where the main goal is to restore blood volume and oxygen carrying capacity. We will also provide analgesia and treat hypovolemia, which we will cover shortly. If the fundus does not feel firm, we will manage this by massaging the fundus in a circular motion, using a cupped hand, and by putting in place the same interventions used to manage a firm fundus: oxygen, pain relief, and hypovolemia management. In 2013, Hofmeyr, Abdalaleem and Abdalaleem conducted a systematic review which found that a uterine massage given every 10 minutes for 60 minutes after placenta delivery is successful in reducing blood loss by 80%. They go on to explain that this technique works by aiding in the natural contraction of the uterus, thus preventing blood loss. The Queensland guidelines outline that this massage may need to be continuous depending on the level of blood loss, whereas the Victorian guidelines outline that the massage should continue until the fundus is firm and blood loss has reduced. Queensland and Victorian guidelines also suggest encouraging the baby to suckle from the mother's breast as a way of managing the hemorrhage if the fundus is not firm. However, a 2016 systematic review by Abedi, Janavar, Nambar and Lee, which examined the effectiveness of breastfeeding and nipple stimulation as a way of reducing postpartum hemorrhage, found there was insufficient evidence to suggest that this technique actually made a difference in reducing blood loss. The Victorian and Queensland CPG also recommend encouraging the mother to empty her bladder. In 2013, McCreish outlined that in order for the uterine massage to be effective, it is necessary that the mother empty her bladder. McCreish goes on to explain that if the uterine massage is not effective due to the bladder being full, the mother will be at an increased risk of an uncontrolled hemorrhage. To manage our patient's pain, we will first need to take into consideration whether or not she is hemodynamically stable. The Queensland Ambulance Service Postpartum Haemorrhage CPG outlines that the normal signs of hemodynamic compromise are often masked by the physiological changes that occur during pregnancy. This means we should be alert to tachycardia and hypertension. If the patient is unstable, we should be cautious if we choose to administer morphine, as it could cause further complications through hypertension. Bernfeld and Cannison explain that pulse, respiratory rate, and blood pressure should be considered before administering a drug that could further compromise hemodynamic stability. In 2010, Fleshman, Fraser, Dyer, Dewey, and Newgard compared the effectiveness and safety of fentanyl and morphine administration in the pre-hospital environment and outlined that fentanyl, due to its small histamine response, is less likely to cause hypertension when compared to morphine. Because our patient most likely already has a low blood pressure due to the hemorrhage, fentanyl would be a more suitable choice. Following the Ambulance Victoria CPG, the initial dose for IV fentanyl is 50 micrograms. If the pain continues, we can administer up to 50 micrograms at 5-minute intervals for a maximum dose of 200 micrograms. Victorian, New South Wales and Queensland CPGs all outline the treatment of hypervolemia if it is present. In 2014, Kwan, Bunn, Chinock and Roberts conducted a systematic review which examined the effect of timing and volume of fluid administration on bleeding patients. In this review, they outlined that although fluid administration will maintain blood pressure, reduce tissue damage, and hopefully prevent shock, it may also worsen bleeding through diluting clotting factors in the blood. Taking this into consideration, we as paramedics must use our clinical judgment prior to administering fluids. We may want to consider a smaller volume of fluid depending on the severity of the hemorrhage and also accept a lower systolic blood pressure. The Ambulance Victoria CPG outlines that an uncontrolled hemorrhage is a modifying factor in the management of hypovolemia. In the case of an uncontrolled hemorrhage, we would accept a palpable carotid pulse and transport immediately. Looking back at our scenario, our patient is hemodynamically stable at present. We would continue to monitor her vital signs and remain alert for any signs of hypovolemia. We need to remember that a woman can lose as much as 30% of her total blood volume before signs of shock begin to appear. If she did deteriorate, we would treat her by following the Victorian hypervolemia guidelines.
Help me, I'm still bleeding.
If the fundus is still not firm following these interventions, we can administer oral misoprostol. The dosage for this drug is 800 micrograms. This drug is indicated for patients with a primary postpartum hemorrhage and is contraindicated in patients with an allergy to prostaglandins and those who are not having a singleton birth. It is a synthetic prostaglandin which enhances uterine contractions. Musa, Blum, Abuasanun, Shakur and Alfeverik explain in their systematic review of postpartum hemorrhage treatments that misoprostol has been reported to have a high success rate of 88% in controlling postpartum bleeding when used alone or in combination with other uteronic agents such as oxytocin. It has a 95% success rate. For oxytocin to be administered, mica will need to be present. Oxytocin is a synthetic oxytocic which stimulates smooth muscle of the uterus, producing contractions. It is indicated for postpartum hemorrhage and contraindicated in those with a previous hypersensitivity, severe preeclampsia, cord prolapse, and those who are not having a singleton birth. The dose for oxytocin is 10 units IM. If the bleeding continues, mica can administer another 10-unit dose after 5 minutes. In the same systematic review of postpartum hemorrhage treatments mentioned previously, it was outlined oxytocin should be used as a first-line therapy for postpartum hemorrhage due to its strong effects on uterine atony. Krishnan, Ogsner and Leknis also outlined that according to the Royal Australian and New Zealand College of Obstetrics and Gynecology, there is no evidence to suggest that misoprostol has any superiority over other oxytoxics. Therefore, as soon as we suspect a postpartum hemorrhage during our initial assessment, we should arrange for mica. If the postpartum hemorrhage continues following previous interventions, we will perform an external abdominal aortic compression. The point of compression is just above the umbilicus and slightly to the left. Apply downward pressure with a closed fist directly through the abdominal wall. To evaluate the effectiveness, assess for a palpable femoral pulse while still maintaining pressure. If you can palpate the pulse, you need to apply more pressure. The World Health Organization recommend this technique, stating that an Australian study examining the hemodynamic effects of the compression can be beneficial in the treatment of postpartum hemorrhage, while resuscitation, management and transport plans are made. It was seen to be successful in 11 of the 20 subjects.
As for transporting our patient, we will follow the Ambulance Victoria CPG. A woman with a postpartum hemorrhage has the potential to deteriorate very quickly due to the condition being a severe complication of pregnancy. If we are in a metropolitan area, we will take our patient to the nearest major hospital capable of accepting obstetric patients. However, if we are in a rural area, we will take our patient to the nearest designated hospital capable of accepting time-critical medical and obstetric patients.